be introducing Julie Wood, the Chief Executive of NHS Clinical Commissioners, and today's webinar is giving you an update on the recent launch of the consultation for over-the-counter medicines. So I'm now going to hand over to Julie, who's going to take you through a number of slides. At the end, there will be an opportunity for us to do a Q&A session. So if you can have a look at the right-hand side of your screen, and you should see there's a space that you can type in questions. So if you could please type those questions in as we go along, and at the end, when Julie's finished the presentation, we'll work through the questions. So, Julie, welcome. Over to you.
Thank you very much, Carol. Good afternoon, everybody. It's one day a week, but you can correct me in a minute. But full part of this week, still with NHS England, on the low-value medicines work, but also is medicines management lead at Islington DC. So I'll a bit start and then hand over to Brian, and then it'll come back to me. Okay, so the agenda for today is to really bring you up to speed with what we're doing in terms of the overall objectives and the proposals that were launched just before Christmas for proposed commissioning guidance on conditions for which over-the-counter items should not routinely be prescribed in primary care. Critically, we want to spend quite a bit of time talking about what CCGs need to do now, and then to get into your questions and answers. I was really keen that we have as early as possible webinar in the new year with CCG medicines management leads, so you've got as much time as possible to be working on a local engagement and consultation with your communities. We sent out a focus on bulletin the day of the launch of the consultation, so hopefully this isn't the first you've heard of it, but we will build on what we sent out before Christmas. So, overall objective for the work, as you will well know, medicine spend is the second largest spend, second only to staffing costs for the NHS, and you can see the size of the spend, almost 17 billion in 2015-16, with a significant increase from the position in 2010-2011 when it was 13 billion, and that figure is rising. Smart use of resources does mean greater funding for other high priority areas that have an impact for patients, and obviously support improvements in service and transformation. And our members, you and your colleagues, have been asking us to coordinate work across the country on your behalf to really get into the whole issue of low-value medicines. Obviously, we started with the 18 medicines that we've now been out of consultation with, but now we're into the next phase and looking at the over-the-counter spend. But the other thing that's really important about this particular piece of work in terms of the objectives is supporting the principle of self-care. We need to, and are keen to, empower people with the confidence and information to look after themselves, which gives them then greater control of their health and encourages behaviours that prevent ill health in the long term. So this isn't just about saving money for use elsewhere in the NHS and higher priority issues. It's also about trying to support and promote the principle of self-care and the empowerment of people to look after themselves more. It's also about reducing demand on general practice. So as this slide suggests, there's 57 million GP consultations nationally for minor conditions at a cost of about £2 billion. The savings that we've identified do not include that £2 billion, but again, if we can do something to reduce the impact on demand on general practice, that would be a helpful thing to do, because we know about it. And of course, the other thing this is about any addressing issues of increased price and any other costs where we see inflated costs above that they can be purchased over the counter. And that, of course, includes further hidden costs, which is prescribing, dispensing and administration costs. So the NHS in totality pays far more for a certain number of the drugs than we would pay if we were to purchase them as individuals over the counter. So that's why we want to do this work. final thing is about reducing variation. We know, and we've now got the graphs, and thank you to Prescript for providing the graphs again, but we see considerable variation across the country from CCGs who have either considered or have already implemented policies to reduce spend on items that can be purchased over the counter. So actually having national support from NHS England that will support local decision making in this area where you wish to take the decisions would actually be really helpful to ensure consistency across the country. So one example of variation, this is analgesia costs. It excludes, as the graph says, POM, cough, cold remedies, but it's the cost between August and October 2017, and you can see the variation with each bar representing an individual CCG. We will be sending out to each CCG one of these graphs with your CCG identified, as we've done for the AT medicines, but all of the sets of conditions we're talking about, so you can see where you are in terms of current spend, and you can see the level of variation. But that's just an example of the analgesia costs, travel sickness costs per thousand. So again, significant variation. So how are proposals developed? In the same way as we developed the proposals in relation to the AT medicines. So as you'll know, we previously consulted on those, and that consultation sought very general views about whether we should look to restrict prescribing of medicines. And we came up with an initial list of 26 minor or self-limiting conditions where prescribing restrictions might be considered. And we wanted people's general feedback. Feedback was generally supportive, as the slide says. 65% agreed that there should be some form of restriction. So we then very rapidly, we must say, developed the proposals for consultation that we launched before Christmas. We've got the clinical working group where CCGs are well represented on that group, jointly chaired by Graham Jackson, co-chair of NHSCC, and Bruce Warner, Deputy Pharmaceutical Officer at NHS England. So we consulted that group on the proposed approach, and based on what they said, we then mapped a whole range of OTC items to the minor conditions for which they are typically prescribed. We then refined the approach to prescribe restrictions based on condition rather than item name or formulation, because it would just be too horrendously complicated to try to come up with proposals by item name or formulation. So we've grouped them into broader conditions. We then used data from the NHS BSA, and you can see the timeline that we used, and that showed that approximately 569 million was spent on OTC medicines. We then tried to look at the biggest items, so analysed medicines falling within the top 90% of OTC medicines to identify how the medicines could be classified for what they might be prescribed. And that 569 then went down to 136 million once all discounts and clawbacks have been accounted for. So the consultation is based on the minor conditions that together constitute a saving of up to 136 million. At this point, I'm going to hand over to Brian, who's going to take you through the detail of the conditions and the approach and the exemptions, and I'll come back in. So if you can tell me when you want slides to move, Brian, I'll move them.
Yep. Okay. Thanks, Julie. So good afternoon, everyone. So this is the list I'm sure you've all read in the consultation. I think it's quite important to note that we're focused on conditions, as Julie said. There's 33 there, plus we've got two items which are slightly different, which is probiotics and vitamins and minerals. I'll primarily focus on conditions for this afternoon. So in July, we released a consultation. 26 of those minor conditions are still there. So dermatitis, dry eyes, earwax, all still there. But after some of the further work and feedback we got during the consultation, we've added some more things to the list. So dandruff and infant colic were some of those added to the list. Then we grouped them into three separate categories, which I'll go through now. So we've items of limited clinical effectiveness, which probiotics, excluding where they're effective for, and vitamins are included there. Then we've conditions where it's self-limiting and does not require medical treatment. And then we've conditions where it is a minor ailment that we believe or we're proposing that it's suitable for self-care, where someone can purchase the item over the counter from a pharmacy. So similar to the guidance that we released before Christmas on the 18th, we've got certain recommendations for prescribers, and we're proposing that for commissioning guidance. So very similar to what we've done before, and touching on the way we've categorized them. Either people should, we can't prescribe them because they're just not effective, or not prescribe them, either they're self-limiting or they're more appropriate for self-care to reduce pressure and cost to the NHS. Again, I can't highlight enough, it keeps coming up perhaps myself when I'm doing presentations, but we're really focused on conditions. It's not actually on individual items. So that means that typically we are asked about paracetamol. We're not looking at long-term conditions. So for paracetamol, where it's used for a long-term condition, that's absolutely fine to continue, but where it's used for minor pain, we are proposing some restrictions. The other exception then, where this minor ailments becomes more complex, or it's no longer minor. So for example, we have migraines included, but where these are very frequent or very severe migraines that don't respond to over-the-counter products, obviously GPs and others will continue to be able to treat those illnesses. And we also want to highlight and reinforce with commissioners, the public, that where the symptoms suggest that it's not a minor condition, we absolutely support treatment and further investigation if that's appropriate. We also, again, touch on more exemptions. Treatment for complex patients, immunosuppressed patients, they should continue to have their treatment where they perhaps need excess monitoring, or where the condition has been caused by a prescription-only medicine or other treatment that's causing an adverse effect. And then our last exemption is where the product license. So obviously the product license, if for an OTC product, it's not appropriate to treat. So a lot of the OTC products, they don't have licenses for perhaps in pregnancy and breastfeeding, or when children are very young. So absolutely a GP or prescriber will continue to be involved in prescribing decisions there. And then one final exemption we do have, that where the clinician considers that patient, their ability to self-care will be compromised or is compromised as a consequence of social, medical, mental health vulnerabilities. For example, if they're currently under some sort of safeguarding alert, there is an exemption there to allow prescribers in exceptional circumstances prescribe if they do think there is a risk to their health. Julie, did you want to take over then about what's going to happen then?
Yes. Okay. So thank you. So they are the proposals, and we launched, as you know, before Christmas. So, but what we've been doing in between time is engaging with the Joint Clinical Working Group and patient groups in developing and refining the draft recommendations, in particular the exceptions which may apply to our guidance. And the exceptions that Brian has taken you through, that we are consulting or included within the consultation, are actually different from the papers that went to the NHS England board meeting back in October, November, I think, that is to reflect the views of Clinical Working Group. In particular, I'd highlight the exemptions around the vulnerability point that Brian talks about, where people have social vulnerability, because there was a lot of concern about how do we handle, what do we do about people who are socially vulnerable, maybe on the basis of income or whatever. And so we actually did include that exemption, which we hope is helpful in helping to guide clinicians, prescribers to be able to prescribe where they feel it's appropriate and not where they feel it's not appropriate. And we also picked up the same sort of messages through the stakeholder events that was attended by groups nationally, which included Patient Association, National Voices and Health Watch England, to test out and further shape and refine the draft proposals. when we did go out to when we did announce the consultation just before Christmas, you may have seen that those groups did indeed come back and have highlighted some concerns already about some of those exemptions, and clearly we'll be looking at all of those as we go through this 3-month consultation period. And this slide really picks that up. So we are aware of a range of concerns about some of those groups, and we do intend to listen very carefully and then look at how we can address the issues that are raised through the consultation process by engaging further with patient groups at a national level that may be affected. And there is quite an extensive national consultation and engagement plan, which I can talk more about if you would like me to during today's webinar. So we did, as I said earlier, refine the proposed exceptions so the consultation period was launched until the 15th of March. We are, as we did before, running a web consultation survey, and the link to it is on this slide, and we expect a whole range of responses to that consultation survey. And we would very much encourage CCGs to respond themselves. It's really important that we hear your views as part of this, as well as the views of individual patient groups. But we will hold a range of other face-to-face and online events, and say quite an extensive engagement process is being developed. And we'll have a number of opportunities. This is the first for CCGs, but there's many others in terms of providing views on the proposals. So what do you need to do now? In order to ensure that the outcomes of the consultation can be implemented swiftly, we are encouraging you to undertake engagement or consultation with your populations for implementation of the draft guidelines in line with the requirements of the Health and Social Care Act. It's really important, like the AT medicines, that you're clear that the actual decision for each of the sets of conditions that we're talking about ultimately will be each individual CCG's decision. So you need to have put yourself in a position to have done as much as you need to do to be able to comply with the requirements for consultation and engagement with the Health and Social Care Act. Clearly, if you're a CCG that have already taken these decisions and your spend is very small, then you may not need to do much at all, other than explain all of that. If you're a CCG that hasn't taken those decisions yet for whatever reason, and you're keen to, then you will want to do much more active engagement and consultation, such that you can defend any ultimate decisions that you take, because it is your statutory responsibility to take those decisions. So by doing that as part of this process, both nationally and locally, it will then allow you to take a rapid local decision on implementation of the final guidance for each condition when it's planned to be published in April 18. So the intention is that there's quite a rapid turnaround from the 20th of March when the consultation ends, 14th of March when the consultation ends, sorry, to early April when we look to publish the finalised guidance, but taking into account what we've heard during the consultation. So I would encourage you to do as much as you need to through this period to allow any rapid decision making that you need to take. So that would then allow you to determine, based on the level of spend and your own policies, what you need to do to bring your population with you. And we are going to share the broad levels of spend that I've talked about already for the conditions in our next Focus On bulletin that will be coming relatively shortly. So, in this national consultation phase, an individual CCG can provide, and we would encourage you to provide a response to the national consultation on the commissioning guidance based on your own local activities. It's up to you what that includes, but it could include, but it's not limited to, your own perspective on the guidance, whether you're supportive, whether you're not, under what circumstances are you supportive, or other things we need to think about in terms of the exemptions or whatever it is. The outcome of any local consultations that you have taken or are going to undertake over the next 3 months, and feedback from your local engagement with your own patient participation groups, your own members, but also local community groups representing people with protected characteristics, health watch and or discussion with your local overview and scrutiny committee of the local authority. Following close of the consultation, NHS England will rapidly feed back to CCGs a summary of the responses received, so you can hear back what we've heard at a national level that hopefully you have fed into. We will then again rapidly through the clinical working group review the responses received and develop finalised guidance, which will then be published in April. And again, the expectation, just like the 18 medicines, is that you have to have due regard to the guidance when making your own local decisions. You can decide not to implement it, but you have to be able to show you've had due regard to it and have reasonable reasons if you're not doing it. And that will impact in part on what your own health impact assessments look like for your own population. We'll be doing and publishing and indeed as the consultation have published an initial health impact assessment, but actually there'll be a more detailed one developed, but you need to do one locally so that you are clear about the impact for patients with protected characteristics on your own population. So that's it for the presentation. We've now got 35 minutes for your questions, comments, feedback, reaction, and anything else that you want to ask. So I've got Thomas here who's managing the questions. So Thomas, are we getting one?
Yeah, so there's a few questions already gone through. The first is on the clarity on the general exemptions, the restrictions details in sections 1, page 9 and 10. There's not making it entirely clear how we ensure we manage children and adults and elderly in the low income bracket are protected. E.g. identified low income or claim benefits, and that's Nick from Wandsworth CCC who's asked about that.
Okay. Brian, do you want to come in on that one? I've got a cold. If I sneeze, I'm sorry. I'm suffering from a minor ailment that I need an OTC medication for.
That's okay. So that's sorry. Sorry, just a problem with my phone there.
So that's it, that one. Onto the exemption one where the vulnerability question comes up.
Yes, so I think in terms of asking about income, we are not explicitly asking for exemptions around income. There's not going to be an exemption. I think this will come up later on, but we are not proposing to make changes, or it's not within our remit to make changes to prescription exemptions. What we do have, and so you mentioned children in particular, where the OTC license doesn't cover children, they continue to be prescribed for. And then comes back Julie, which she highlighted, was if there is, where the clinician thinks there's going to be adversely affect their ability to self-care due to their social and medical histories or potentially a safeguarding issue, clinicians could in exceptional circumstances continue to self-care. But I think we all recognise that there is a risk people on low incomes, or if the exemption criteria that we put in there get misinterpreted, as they sometimes do when we're all busy on the front line, that there could be some things that or unintended consequences that we haven't quite envisaged.
Yes, it's whether your prescribers, Nick, can use or feel that the definition of social vulnerability might include ability to pay. So if as a result of having to pay for these prescriptions they become more socially vulnerable, then my own personal view is that that's covered by that exemption, even though it doesn't explicitly say ability to pay. We agonised long and hard over trying to get some wording that was reasonable and it would ensure that prescribers could use social vulnerability to cover that where they wish to. So that's the wording that we've come up with. If you feel it's not sufficient and there are concerns, then please do say so. We need to hear particularly from CCGs from our point of view, because actually we're acting on your behalf. So if you feel that this doesn't go far enough and doesn't cover the issues that you want it to cover, then you need to tell us. so we can reflect on that during the consultation, because I'm sure we will hear from patient groups quite loudly about these things, and whether you have the same view or a different view, we need to hear it.
Yes, the next question comes from Mira Prakash, who asks, is there an update on the gluten-free prescribing consultation?
No, I'm afraid not. We were hoping before the reshuffle that we might have an outcome. I was told and reassured that it was on the Minister's desk way before Christmas, but it's probably on the same Minister's desk, because I don't think the relevant Minister has moved, given there's only Philip Dunn who has moved or left. But we haven't, Mira, got an outcome to report, I'm afraid. I'm hoping it's imminent. I don't know, Carol, if you've heard any more, or Brian, if you've heard any more, you can say.
No, I asked Claire Potter before Christmas, that week, the meeting we had just before Christmas, and she said exactly that. It's with ministers, and we're just waiting for them. She thought it was imminent, so as you say, the reshuffle may have just caused a bit of a delay.
Okay.
Next question from Prina. When will the CCG specific data be sent out? I can possibly answer that one.
Yes,
the Focus On bulletin will go out on Thursday, and that goes to the chairs, chief officers, and medicines optimization leads. And within that will be the links to the graphs, anonymized by CCGs, and it will be using the same codes that we used for the previous graphs that we sent out as part of the 18 medicine consultation. So those will be sent out on Friday.
Yeah. Also, we will be putting them onto our website as well, under the OTC section. So there'll be, we'll have them all named ones on our website too.
Excellent, thank you.
Next question from Sarah Crotty. Have issues with GMS contracts GPs should prescribe been addressed?
They've certainly been identified by the clinical working group, particularly, not surprisingly, by the GPC and our CGP members of that group. We think we're okay in terms of wording, but what we need to do is make sure we get the wording that, or at least the rationale why we think it's all right, out to you via a focus on. Certainly for GMC guidance, I think it's fine, because in order to comply with the doctor, the giving advice as opposed to issuing a prescription is perfectly valid. So I don't think there's GMC issues in relation to the OTC ones. Recheck the wording of the GMS regs and if you like, our rationale as to why we think there is a reasonable position to take. And that will be based upon a number of CCGs who've already done some of this work and have actually sort of looked at this. So we will get that out to you in terms of this Thursday's Focus On bulletin. I can expect it to remain an issue with colleagues on the GPC and the RCGP, and part of the engagement plan for the next 3 months does involve we need to have a number of specific conversations with primary care providers. So via the GPC and via the RCGP, because we really need this not to be a deal breaker, in effect. So we'll continue doing that, and we'll get the information out to you that we think is a defensible position to take, if that's okay.
Question is, why was hay fever not included in the original, in the 33?
Oh, okay. Expert pharmacist, Brian, Carol, why didn't we include hay fever? Well, we had, didn't we? I don't know.
Brian? Has Brian disappeared? Perhaps he's on mute.
On mute, probably. Takes ages to unmute.
Yeah.
Carol, can you?
I don't know really. The Bhavna did the original analysis of the data for the OTC. So I think it's probably maybe something for phase 2. So I don't know the answer to that. We'll have to look into that one with the group.
Yeah, and there was, so my recollection was there was a bit of disagreement there, and whether it was hay fever or long-term condition, for which we've included an explicit exception as well.
Yeah.
But I think we can check that out and get you a more cohesive answer.
Okay, we'll come back. Sarah. We'll come back to you, Sarah, on that one. Okay.
So there's another question around social vulnerability, but I think we've covered that, and also about availability of prescribed graphs. How has CCG comms team been informed about this work? From Helen.
Okay, so Helen.
I can probably
yes,
answer
you
this
can.
one. So we've sent out an engagement directly to all the CCG comms and engagement leads via NHS England. NHSCC and NHS England are also hosting a webinar on next Friday, for comms and engagement leads, and we've already got 64 people signed up to that. So it's really at this stage about if there is someone within your team and in your local CCG who should be on that call, signposting into it. We'll include all the details we focus on, which goes out to leaders, so that's CCG chairs and chief officers, and yourselves. So the top of the office should know about it, but then also hopefully the engagement lead should know about it through NHS England.
Please, if at a local level you can connect yourselves up. So we're doing it nationally, but you need to be doing it locally as well. So that you are talking with your comms and engagement leads about what you need to do for your population, depending on whichever, if you like, specialism or station that you're coming from.
The next question is around resources available we can use for local engagement consultation from Beth.
Yes. So Carol, Brian, do you want to say what we are doing?
Yeah. Absolutely. So we had a conversation this morning with NHS England, and I think first of all we are going to be looking at copying across directly the tags, so that we can produce the EPAC data to reflect all the elements and conditions that are listed in the consultation. So we need to make sure we've got accurate data to start with, and produce regular updates for the CCGs. We also we're going to have a meeting with the NHS England Self-Care Forum to look at what resources we have between us and what else is out there, so that we are making sure that signpost everyone to existing resources. We have got quite a bit of work already on our website. From a prescript point of view, we have a self-care campaign that we have been working on over the last 6 months or so, and that should be able to be launched. That's very much focused around having a well-stocked medicines cabinet at home, so that sort of element of it. We're also going to be doing some infographics for CCG, so that you should be able to produce some local data you can import data from from our OTC OTC medicines data that's personalised, bespoke for the CCG, so it can say in there, our total spend on OTC medicines is X, and with if we save this money, we could have so many hip operations or whatever. So we're going to do those for a range of OTC conditions, so to help promote that, so that you can locally be able to do your own bespoke versions of those to help support that. And then we're going to be looking to see what other resource materials perhaps are needed, and work between ourselves and the Self-Care Forum to look at what we can help to support. So if there are particular things that CCGs feel they would need and would be helpful, then it would be great to let us know that, so that we can try and ensure that does get produced to help support this agenda.
Yeah, there was an issue that came up when we had the initial consultation about translated material that we need to think about, and also material, easy read material for patients and carers who are looking after people, supporting people with learning difficulties. And so when we have the relevant engagement meetings, I'm sure that's going to come up again. So we need to think and make sure we've covered off all those sorts of things. There was also quite a big push, wasn't there, Carol, around things like, should we do more around social marketing? How can we use Twitter to sort of get the word out, but also support self-care
I think the whole, so the whole, like you say, campaign around self-care and pharmacy first is really where we need to be. Absolutely.
Yeah. Okay, brilliant. Thank you. Right, some questions coming through.
Yeah. So question from
sorry. Could I just come back on the hay fever question?
Yeah.
I've just come back from a colleague, and we've included minor hay fever in the consultation, and we excluded the long-term or serious hay fever.
Oh, right. Okay.
So it is actually in the consultation, mild hay fever.
It's just not on that list.
I thought we'd done an antihistamine, OTC antihistamine graph. Yeah, thanks. I haven't got it in front of me at the moment.
Okay. Great. Thank you, Brian. Okay, so a question from Eileen about care homes.
Yes, so trying to with the particular locally where care homes are requesting OTC personal care, how we could best manage this cohort of patients.
Yeah, this has come up on the working group, hasn't it, Carol? So,
yeah. We've got a care home call tomorrow. We've got as a virtual professional network group for care home pharmacists, and that's on the agenda for discussion tomorrow, looking at some of the sort of pros and cons around this area. So I think there's not a simple, easy answer. So if you're free and you want to sign up for that for tomorrow, we can have a bit more of an in-depth discussion. And we've got the NHS England Care Homes lead joining the call as well. So that might be helpful.
Okay. So Eileen, if you can join, please do.
Next question from Emma. Will the guidance include specific advice to GPs, other prescribers relating to their contracts, professional body advice?
So I doubt that the final guidance will, because it will just be clinical commissioning guidance for each condition. We are, as part of this process, going to be trying to develop, if you like, our view about the position with regard to, as I said earlier, GMC advice, but also GMS regs. And we are also aware of work that was done in one part of the world with NHS England colleagues who very helpfully said, well, and they listed it, if you've done X, Y, and Z, then we are highly unlikely to be taking forward on any contractual, if you like, sanction basis, anything in relation to non-prescribing. So we are going to try and push that conversation a bit further to see if we can get NHS England to sign up across the board to something like that. I may not be successful, Emma, but I'll try. We'll try and see how far we can get it, so that it can be as helpful as possible to you locally. And as I say, we do intend to have specific and the RCGP, and clearly the GPC, this is where they all are, and they want the contract amended. I'm not sure we're going to get the contract amended, so I think we need to push it as far as we can about this is what we think is reasonable to be interpreted in terms of how you can act, which then hopefully will be useful for you with your local conversations with LMCs, because I know some are helpful, but some are less helpful, and with your own member practices. So hopefully that will help a bit, depending on where we get to.
Next question is from Sharon Braybrook, asking how will this affect minor ailment schemes via community pharmacy? Very limited local MAS OTC list for patients.
Yeah.
Charges.
Again, this is an issue that the working group touched upon, but haven't really resolved, because if we are saying that we do not believe, or we're consulting on the fact that we do not routinely spending NHS money on these medicines for these conditions, then at one level it shouldn't matter where the, if like, prescribing of such items is. It should be excluded, which is the principle. So that will include then pharmacy minor ailment schemes. However, there is a slightly sort of different view, and this is where the vulnerability question comes in, about whether in limited circumstances should you be still having those schemes in place. So again, it would be good to get your views on that as part of this consultation. But Brian, I don't know if you want to add anything from an NHS England perspective in relation to schemes.
Yeah. Yeah, no, we'd be very keen for as views on this as possible. I think it's worth remembering that most schemes where they are commissioned by CCGs, and CCGs will have, take our guidance into account and probably should review their schemes after we release guidance. I am aware, and we'll deal with, there's a couple of CCGs primarily in London, where it's more NHS commissioned, but that's a very small number of CCGs, and we'll be contacting them directly with the NHS and colleagues around plans for how we review that.
Yeah. So you will. So for the CCG commission schemes, CCGs will need to have a think about whether whether it's consistent. If you support the guidance and you want to implement the guidance in relation to FP10 prescribing, then you'll need to think about, well, is our position with regard to investing in community pharmacists to do the same thing consistent or inconsistent? And if it's inconsistent, is it inconsistent but legitimately so because you're concerned about vulnerability, or not? And take your own local decision about that. But it will be good to get people's views about that.
Another question from Emma. OTCs will be sold recommended according to the product license. So a suggestion that needs supporting info for prescribers to understand these nuances rather than condition product info only.
Yes, I think this has come out as well in the group, that we need to be clear with prescribers and with patients about when you can and when you can't. We were hearing examples where prescribers were currently confused. So again, I think this is something, Carol, Brian, for the supporting materials.
I think you're absolutely right. There's certain things that the age restrictions that some of the GPs might not be aware of because they're so used to prescribing it, and if they for that indication signpost everybody to OTC without realising that there's an age limit and the community pharmacy can't supply. So I think for perhaps some of the very popular items, we might produce some information, leaflets for GPs and for patients as well, to just kind of explain what those exceptions
and
are.
I just add that we have started to engage with the GP system suppliers who provide the IT systems where GPs record their notes, code, etc. And we've asked them to feed into consultation and start thinking about how their systems could support this, because even trying to remember the whole list for an individual GP or healthcare professional is going to be very difficult. So if you have suggestions on the IT side of things, please send them into the consultation response.
Yeah. We've got the RPS on the clinical working group who have a particular position with regard to this, but we do need to think about, and I've just written myself a note about how we engage with community pharmacists as well on all of these things. Yeah,
that's the feedback I've actually had from quite a few CCGs, Julie, is actually, how can we get the community pharmacists locally on board with this? And, if we are going to be doing some sort of campaigns, we really need to be working very hard with community pharmacists. They are commissioned by NHS England, to try and get them to support it. I mean, I know the RPS and the PSNC aren't at the top, but it's about how we get that local engagement and get the community pharmacists on board. And they are on board in lots of CCGs because they are running pharmacy first schemes and using community pharmacy and referring. And it's really about how we just make sure we bring everybody along with us around in the community pharmacy. So we're singing from the same hymn sheet to the patients, I think, is absolutely key. But it's all about access, isn't it, in the GP surgery, and trying to ensure that we stop the patients cluttering up the surgery with these minor conditions.
Yeah, so I think we need to flag that up, Brian, with Heather colleagues and look at how we can engage through any national mechanisms for community pharmacies. I don't know what the answer is on that one. But.
So we've got a few people pointing out that HAFIV is concluded with the consultation document, but not on that slide. So I think
we'll correct the slide. Thank you.
However, there was also a question around the HAFIV spend at 1.1 million, seeming quite low. So I don't know, Brian, if you wanted to say something about how you reached that figure.
Yes, I think this comes back to the definitions where we use for it was more long-term, where someone's having it continuously, or whether it's just more mild and intermittent, where people have prescriptions off and on. But we're looking to get the lists out to press, Squip and NHSCC, and there'll be more hopefully more information about the definitions we used.
Okay, thank you. Okay, from care homes to schools.
Yeah, so a question from Karen about schools medicines policy only allow medicines to be given if they are labelled. Could this be factored into the guidance to support schools' administration of OTC medicines?
Yeah, we've had a huge number of issues around schools, around the OTC, and also around some other areas. So Prescript have got this on our list of things we're going out to the CCGs to ask if they want some sort of extra support around school policies, in particular around all prescribing to the schools. But there has been some work done around this by other CCGs already. So I will try and find that, and we can sort of circulate that following this this webinar to the CCGs, because I think my understanding is that you don't have to have it labelled. I think it has to be named. And so therefore, you can go and buy something as long as it's named. So there are some policies out there already and some guidance. We just need to all be more aware of it. So we will be doing something with Prescript to try and pull that together for you into one place.
Okay, thank you. We also perhaps need to think about interaction with the LGA. I know not all schools are under local authority control anymore, but we need to see what we can do with local government association in relation to this generally, but then specifically schools and care homes, really. So we need to think about that as well. That's just struck me. We'll do that as well.
Yeah.
Question here from Elizabeth. Prescript details all the item codes for items of least clinical value. Can you share the detail on what you have included to identify the savings on these OTC items, even though you say based on conditions? So probably one for you there, Carol. Okay.
Yeah, absolutely. So the graphs that we've currently provided that you've got are based on the Prescript OTC medicines, and on our website there are tags for each of those. If you have a look at there, I think there's sort of at the bottom of the website it says there's a link through, and you can actually look and see exactly what's in each tag for all the work we do. So that's the low value medicines and the OTC. So there is a listing about what's included and what's not included. So the work that we discussed this morning with Brian and Alex from NHS England was about ensuring that we've got the same tag listings that correspond to the values that were put into the consultation document. So you will see the things that we haven't got in those graphs. So we haven't got dandruff, for example, and there's some other things missing that we haven't got. So we will be pulling those together over the next couple of months for you. So we will have a complete set of data that corresponds to the consultation document. I hope that helps.
Okay. Thanks, Carol. Okay, got a question here.
Yeah, question from Azalea. Proposal states CCGs should ensure that community pharmacists are reminded of red flag symptoms for patients presenting with symptoms related to the conditions covered by the consultation. Appreciate that conditions are implemented will depend on each CCG, but would it reduce duplication of effort if or commission development of central documents to support community pharmacists, including for red flag symptoms covering all areas? Community pharmacists access when prescriptions were applicable as needed.
Come, Brian. Well, I was going to say that I read this when we had the consultation document, because I think it's saying for CCGs to help with this, and I did point out that actually it is NHS England's role with the community pharmacies. But I think I think that's an excellent suggestion that's been made, and something that I'm sure either NHS England or Prescript could do, or we could do on behalf of. But I think it's a very important piece of work that we could do.
Yeah, and I think it's just worth remembering as well that we have the Centre for Postgraduate Pharmacy Education, who have a lot around minor ailments as well. Minor ailments is more embedded in the undergraduate courses that pharmacists are trained in now. So there is plenty out there, and I'm quite confident our colleagues and community pharmacists are dealing with this every day. So it might be more trying to deal with outliers who aren't.
Okay, thank you. Right. We have got 5 more minutes or so.
Yeah, question from Usha is, Is migraine totally excluded? Do you want to quickly talk about that, Brian?
No, it's included in the guidance. We do have migraine there, and it's mild. It can be treated over the counter.
It's in the detail of the consultation document.
Question from Helen Marlowe. What engagement has there been with nurses regarding the products and the community practitioners?
Good question. I think the answer is none to date, but we've got time. So again, we need to think about how we do that.
Question around an LPC stating an ethical obligation to prescribe what they recommended. Can this be considered within the final guidance? I think we covered that.
Yeah.
A suggestion from Kate that clinical systems need to be able to record OTC more easily. Has this been requested in guidance for PCPs?
I think that's what Brian just talked about, Kate. A couple of people asked for the details of the care homes webinar tomorrow, Carol, so whether you can...
Okay, Kirsty, we can ping something around to everybody for that. Yeah, it's on the website, so you should be able to go onto the website and be able to register for that. It's between 1 and 2 tomorrow.
And then another question around Sarah around how to implement policies where mild is included but severe is not, and the definition of mild or severe.
Yeah, we had some interesting conversations about mild diarrhea as opposed to severe diarrhea and things like that. So if you feel, I don't know whether we will get, I doubt that we will get a further definition. It's up to the prescriber to decide. So if you decide to implement the final guidance when it comes out, and then it's still up to the prescriber to decide whether to implement it for that patient sitting in front of them. So I think that may be where we end up, unless either Carol or Brian thinks we're going to get better definitions from the work group. I doubt it.
Yeah, I think it's just worth remembering that this is commissioning guidance and not clinical guidance. So the likes of NICE and that are responsible for issuing clinical guidance. But I agree with Julie, I think we've probably gone as far on the definitions as we can. But I'm quite confident a lot of our GPs can distinguish using common sense and their diagnostic skills between mild, moderate, and severe.
Yeah, absolutely.
Okay, final couple of questions before we seek to wrap up.
I think just a question here from Usha around dietitians recommending OTC food products. I'm not sure whether that was
food products on the list.
So
whether there is a later phase in relation to sick feeds, other foods, whatever, but it's not included as part of this particular consultation. So if you think we should go further and include something in a later stage, then again, please let us know. And we will consider that as part of our ongoing work. So
can I just add just on that? We do have probiotics in there, and we do have ACBS criteria. That's already nationally established criteria for what multi-dietitians can be recommended that can be prescribed. So what we found in the variation that it's actually a matter of policing. So some areas are quite hot and ensuring people meet the criteria, and some areas aren't. So maybe in the first instance, worth looking again at your sort of enforcement or dietitian's knowledge of ACBS criteria.
Yeah, okay, thank you. So in the final couple of minutes, just want to flag up some of the other things that are happening. So I've gone back to the slide that has got the link to the web consultation survey, but we have 3 national face-to-face events that are now set up for general patients and the public. So if you want to come along to those, you are, of course, more than welcome. 30th of January, we'll include all of these in Focus On, so don't worry about scribbling down all the details. But we're in Leeds first, 30th of January. Then we go to Birmingham on the 9th of February, and you'll have the pleasure of seeing me at those, or not, as the case may be. And then there's one on the 5th of March in London, and we're just looking at who from NHSCC will be there, as well as colleagues from NHS England. Then a couple of patient webinars, again, 22nd of January and the 21st of February. And then a whole host of other events with different patient groups and charities, including older people, people on low income, other vulnerable groups, learning disabilities, dermatology, not entirely sure why, children and young people, say GPs, we've talked about, we haven't got dates, but industry also, parliamentarians, health and justice community, and I think we need to pick up now community pharmacists. And then think about schools and care homes and how we engage with local government. So that's just, as well as national associations like National Voices, Health Watch and the Patients Association. So that's the scope of what we're doing nationally. That will hopefully be helpful, but in addition, obviously, as we've said, you need to do as much as you need to locally to feel that you can take your own local decisions based on what you've heard and what you've received back as a result of the national consultation. So, if you have further queries, you can send them to us at NHSCC via the General Office email. You've got that on the slide, or further inquiries to NHS England through the NHS England website, which again is listed. Other comments, queries, really pleased to hear from you. I'm sure Carol and script colleagues will be too. If there's any big gaps that you think we've not covered off when you reflect on this, then please let us know, because we need to do as much as we can to support you to take your own decision. So that's going to be really important to do that, so that we take that forward in the right way and support you in making the right decisions. So without further ado, it's now 2 o'clock, so can I thank all of you? Can I thank Brian, McKenna and Carol Roberts for their contribution, and to Script for hosting today's webinar, and have a good afternoon, and thank you. Goodbye.
Yeah, thank you very much, Julie. Okay, and goodbye, everybody. Thanks, Brian. Okay, bye.